Hello, dear colleagues. My name is Vsevolod Potapenko. I'm from Russia, hematologist. I work in Municipal Hospital number 31, St. Petersburg. Educational work induces to read scientific papers. So I'm planning to make a short course, something like selected topics of hematology. And today I'd like to talk about secondary hemophagocytic lymphohistiocytosis. It is met much more often than it's think before, but due to inflammatory complaints, symptoms, these patients usually are managed as septic ones, and I think it's no good because the treatment is different. Due to different reasons, this theme doesn't sound on the big and prestigious medical conferences sponsored by Global Pharmacy. So, in our hospital, we make research about the syndrome for 13 years. So, I would like to share with you with our results. My lecture has two parts. The first one will be the general review about pathogenesis, diagnosing, and treatment of HLH. And the second part will be about our center experience of managing such patients. I will be very grateful for any questions and any feedback. So, let's start. I will talk about pathogenesis, clinical manifestations, diagnosing and differential, some words about treatment, and particular manifestations of secondary hemophagocytic syndrome due to different reasons. So, what is it? Hemophagocytic lymphohistiocytosis. So, hemophagocytic lymphohistiocytosis, HLH, can be primary and secondary. Primary appears usually in children under 1 year old. There are genetic mutations which are well defined, and pediatricians know this disease quite well. That's why we'll talk about secondary HLH. And secondary HLH can be in all people, including adult ones. And 40% of them has tumor as a cause, 40% has infection, such as Epstein-Barr viral infection, and every fifth patient has cryptogenic, because sometimes it's hard to identify the cause of secondary HLH. What is the pathogenesis of it? I think that quite good describe the pathogenesis, the scheme which was published in 2001. We see the HLH associated with the Epstein-Barr viral infection. In a patient with severe EBV, CTL and NK cells forgot how to kill the infected cells. It causes the positive feedback and storm-like activation of immune system with the involvement of other chains such as monocytes and macrophages. Cytokine storm appears, and the patients usually die because of multi-organ failure. On this slide, we see the general scheme of time of HLH. The International Histiocytic Society people usually divide the cause of HLH on two parts: the stabilization phase and destabilization phase. I think that it's better to add the third one, the cytokine explosion, when the situation worsens very fast. The stabilization phase usually lasts for some weeks. These people complain on fever and mild fatigue, but they usually continue to work and to, for example, study. The acceleration phase includes the deterioration. The patients feel worse, the fatigue increases, and sometimes their organ failure appears, usually CNS or lung impairment. In the acceleration phase, the people usually come to doctor, to hospital, and the process of diagnosing and treatment intensifies. And we have to think quite fast. But the fastest thinking have to be in the period of cytokine explosion. These patients are really has a lot of common features with septic ones. So the antibiotics and the immunosuppression in the case of HLH have to be timely. And the best time is the acceleration phase. But of course, in the cytokine explosion, we also have to treat, because the border between two phases are quite elusive. So, what are the main manifestations of secondary HLH? These patients have a lot of similar features with septic ones. So, febrile fever resistant to anti-infective activity is the main, is the visit card of the HLH. Cytopenia is also can be in HLH, and the mechanism of it is inflammatory. The organ impairment adds later, and usually it includes lung and brain, with histological signs as lymphohistiocytic infiltration, aseptic inflammation, edema, sometimes with the infection also features. So we see that the signs are very unspecific. How organ impairment looks like. Liver and spleen are very often impaired in secondary HLH. The spleen is usually enlarged, and liver enlargement is often can be, but a little bit rare than the spleen. But the biochemical features of liver involvement usually comes along with the secondary HLH. Cytolytic and cholestasis syndrome has almost all patients with HLH, but it is usually clinically insignificant. So doctors sometimes think that the biochemical changes are due to maybe the drugs or maybe alcohol consumption, which patients don't tell to us, or maybe some other causes. But mild liver impairment, biochemical liver impairment, occurs very often in secondary HLH. What about CNS? The symptoms are very non-specific. It can be severe asthenia, convulsions, coma, hallucinosis, vomiting, and so on. But the MRI examination or cerebral fluid examination show very non-specific features. Of course, there can be mild hyperproteinuria or very mild pleocytosis, but very, very mild. What about lung impairment? The frequency is something like 50%. The main symptoms are inspiratory shortness of breath, and the X-ray picture is also non-specific. It usually looks like non-cardiogenic pulmonary edema, but sometimes less often it can have bilateral multifocal lesions, migrating infiltrates, and so on. Some words about cardiovascular involvement. The frequency is not more than 10%, but if the suspicion in the center is high, the frequency will be low. If the HLH suspicion will be low, the frequency will be high of cardiovascular involvement. The manifestations are arrhythmia and arterial hypertension, which makes the patients similar to septic ones, but the treatment is different. What about skin? The cutaneous manifestations include polymorphic rash, itching, pain, sometimes epidermolysis, and so on. And the rash can be very different, even in one patient. On the picture we see a man with both small point rash on the forehead and near his eyes, and big ecchymosis on the chest. So we talked about secondary HLH, and we saw that the symptoms are quite unspecific. So what do we need to diagnose the secondary HLH? So let's start with the hemophagocytosis from the morphology. And this is the terminological trap. We say hemophagocytic syndrome, so show us the hemophagocytosis. But this phenomenon is quite non-specific because hemophagocytosis can be in the sepsis, in the infection, in cancers, and so on. And at the beginning of the HLH, we can see no hemophagocytosis in the bone marrow. So the phenomenon is quite non-specific, and the value in HLH is non-principal. But if we don't treat the HLH, the number of the macrophages with phagocytosis will increase as the HLH progresses. And it's true, the morphology requires a qualified morphologist, because when we started this work, our doctors said to us that they saw the macrophages but did not describe them because they thought that it is not important. So criteria HLH 2004. They were invented for pediatric, for children to diagnose primary HLH. But are they so good in adult HLH, in secondary one? The molecular diagnosis usually doesn't important in adult HLH, and the value of fever for 7 days, for only 7 days, as well as mild cytopenias, is quite subtle, because in adult people we will not think about HLH as a first disease in patients with high fever, with mild cytopenias, or with high triglycerides or low fibrinogen, as well as low absent NK cell activity and soluble CD25. These tests are not available in the routine practice. Ferritin more than 500, but the ferritin is acute phase protein. So I think that the criteria HLH 2004 is quite sensitive but very non-specific. The situation improved when H-score was published in 2014. This scheme is new and more convenient because it includes the more reproducible parameters, and it uses the scores. Each score includes the temperature value, the liver and skin enlargement, number of cytopenias, ferritin levels, but the thresholds are not 500, but 2,000 and 6,000. High triglycerides, low fibrinogen, and serum glutamine oxaloacetic transaminase, which is more specific for the whole organism than the second transaminase. And of course, H-score includes hemophagocytic features in bone marrow. The simple and free calculators are available in the internet, and they count the probability of secondary HLH. But there is one problem. H-score and HLH 2004 work best in the situation when the patient feels very bad in the acceleration or cytokine explosion phases. In the stabilization phase, before the organ impairment, these scores work quite weak. But ferritin can help us. Ferritin is one of the typical biochemical markers, and it elevates before the other signs of HLH appear. The cause of elevation is unknown, but mild elevation of, as I have already said, can be the first sign of HLH. It's very important for diagnosing and before treatment, but it's not so good for monitoring of the disease, because a lot of patients with the clinical improvement has high ferritin for some time. And there is one more interesting feature of this marker. Fold rising of the ferritin can for 1 to 2 days preclude the clinical deterioration. So it is very important marker for monitoring of the disease before treatment. One more feature about ferritin. If the concentration of it is very high, even using the new machines, we can have the hook effect, the false low results if the concentration is extremely high. That's because the reagent cannot bind all ferritin in the probe, and the non-bind ferritin will be eluted. So the biochemist usually knows about this phenomenon, and they can make their repeat analysis in the diluted serums. So if the result is low and the suspicion of secondary HLH is high, for example, cytolysis unexplained, cholestasis, fever, and cytopenia, it's worth to talk with biochemists to perform a series of dilution tests to get the correct result. During our work, we also were afraid of sepsis. So, how to distinguish these two situations? We decided to make the small research to compare the laboratory profile of these conditions, because clinically they are quite similar. The main results are on the slide. The sepsis patients had infection shock, and mostly in our trial we took their last day blood of their life. We see that C-reactive protein and procalcitonin are elevated in both conditions, but triglycerides and SGOT and SGPT are also elevated in HLH, in a live HLH, and the median values are normal in patients with lethal sepsis. We see that creatinine is high in sepsis and normal in HLH. In patients without chemotherapy, we compared platelets, and we see that HLH patient has low platelet counts, comparing with sepsis 1. So we see that there is the distinct inflammatory pattern in patients with secondary HLH, and we can use it to distinguish these two conditions. Or sometimes maybe say that sepsis can be complicated with HLH. But what about ferritin? The ferritin level is extremely high in HLH patients. The median is 10,000. We see that quartiles do not interact. So ferritin is a very important marker in distinguishing sepsis, shock, and HLH. So we talk about diagnosing. I tried to say that the criteria scheme H-score is better than more old HLH 2004, that ferritin is as well as transaminases, platelets, and triglyceride is a good differential marker. Now let's talk about treatment of secondary HLH. As we talk that the HLH is secondary, so we have to search and treat the probable cause of HLH. But if the patient has the features of secondary HLH, and if his condition goes down, we have to start timely immunosuppressive treatment. And as in sepsis, the decision-making have to be very fast. And the main drug for HLH now is etoposide. It was very hard to us to initiate etoposide for patients with features like sepsis. But it's one of the best drugs in HLH treatment, including patients with multi-organ failure, because it's like a bucket of water for the fire. It helps very fast, in a few hours. The fever resolves and the general condition improves. The etoposide is the chemo drug for chemotherapy. But here it is used even for patients without any signs of blood malignancy. It's quite cheap, so the hospitals can buy it. And the dose is quite low, and only one infusion usually helps to our patients. The frequency of the improvement is something like 50%, but it depends on what patients are treated. If the HLH accompanies, for example, chemo-resistant acute leukemia, the etoposide will not help, unfortunately, because in some of the patients, the HLH is the mechanism of death. But in, for example, EBV-associated HLH, timely administered etoposide leads to improvement in almost all patients. So now etoposide is one of the best, and it's worth to try it, even in the patients with multiple organ failure, with low temperature and other features of pre-death condition, because this treatment is very effective. One of the fear of etoposide treatment is the afraidness that it will cause the cytopenia. Of course, it could be, but the 50 milligrams or 100 milligrams is a very small dose, and the opposite. After the infusion, we usually see the improvement of the counts. So it's hard, but it's better not to be afraid and to start the treatment with etoposide. Then another drug is immunoglobulin, but the dosage is very big, 2 grams per kilogram, and the price is very high. And immunoglobulin works bad in the situation with cancer-associated HLH and EBV-associated HLH. But it's non-toxic, so in the other situations, it's worth to try. Another drug, ruxolitinib, is also used in the HLH. It's quite new. It is a target drug for chronic myeloproliferative neoplasms. And it also works very good. And I think that in the nearest future, these three drugs, etoposide, immunoglobulin, and ruxolitinib, will share their main places in HLH treatment. Of course, if the condition is hyperimmune, so glucocorticosteroids have to be used, but their efficacy is quite limited. But in the patients with connective tissue diseases, the efficacy is well. So dexamethasone is worth to use for such patients. Of course, there are some other drugs and methods for treatment for resistant patients. These anti-cytokine drugs or maybe rituximab or splenectomy, but this is the reserve methods. But of course, in the resistant patients, it's worth to try. How to assess the result, the response? The main result of our treatment have to be the clinical improvement, and apyrexia is one of it. Usually, these patients respond very fast, within a few hours, and the laboratory improvement starts also in the during the first day of the effective treatment. Some indicators, some tests, for example, INR, cytopenia, alkaline phosphatase activity, can worse for a few days, but it's not bad. Complete regression of organ dysfunction can be during the several weeks. But I will repeat, the main result is clinical improvement and resolution of the fever. What are the most common variants of HLH? The most common is HLH associated with EBV. And the goal of our treatment is to survive the disease, to stop the hyperinflammatory condition, to let the patient to get the immunity against this virus. The main treatment is etoposide, and the treatment have to be timely. Early administration improves the prognosis. We see that the number of the survival patients is near 90% in patients who got the etoposide during the first month after the onset of the disease. HLH associated with lymphoma is also a frequent reason, and it usually outruns the appearance of enlarged lymph nodes. That's why all patients now with HLH who come to our center usually get the trephine biopsy of the bone marrow during the first hours. Then we start our treatment, and sometimes the patients after 1 or 2 weeks get the diagnosis of lymphoma, and they continue their chemotherapy. But they usually start the first course in much better condition than they come to us before etoposide. And sometimes glucocorticosteroids are used overload as palliation, short time for palliation for the patients with lymphoma. In patients with HLH and lymphoma, the glucocorticosteroids are non-effective. In such patients, etoposide is the best. What about HLH associated with collagenoses? In such patients, the HLH is called macrophage activation syndrome. More often, it is a complication of adult use disease. This is the visit card of the AOSD. But macrophage activation syndrome quite good responses to glucocorticosteroid therapy. So the HLH in patients with collagenoses usually has better prognosis against the other variants of secondary HLH. But for hormone-resistant patients, we have to use all spectrum of immunosuppression, include etoposide, anti-cytokine drugs, and so on. So, the conclusions. Hemophagocytic syndrome is always a complication, but not a single disease. Clinical manifestations are non-specific, and we usually have to use the criteria schemes for diagnosing and for differential. The main laboratory manifestation of secondary HLH are severe hyperferritinemia and increased transaminase activity, cholestasis, and cytopenia. In all patients, we have to exclude lymphoma, EBV infection, and collagenoses. Treat the cause of HLH, but if the condition worsening, glucocorticosteroids, large doses of intravenous immunoglobulin, and etoposide are the main drugs for secondary HLH. That's all I would like to say. I would be very grateful for any questions and any feedback. Thank you for your attention.